So I'm Hans Anderson, and it's my pleasure to introduce to you Joseph Bocchini. Dr. Bocchini is an pediatric infectious disease specialist who comes to us from Shreveport, Louisiana, and I have to come to Asheville to meet him for the first time. So it's lovely to have had that chance in any case. He's the current chair of the LSU Health Sciences Center Pediatric Department in Shreveport, Louisiana, and he's also the current chair of the the Discretionary Secretary's Advisory Committee on Heritable Disorders and in Newborns and Children. Anyway, Dr. Bocchini, thanks so much for coming, and we look forward very much to hearing from you about the committee.
All right, good afternoon. First, I want to thank you for the opportunity to be here, to come here, and it's nice that I had a chance to meet Hans, even though it's in Asheville, which is not a bad place to meet people. But if you decide to go to Puerto Rico, I would like to see him again, so I can thank you again. Okay. I want to give you an update on the committee and its current projects, but I think that things that Dr. Singh said and then that Dr. Watson said are very important. I think we're in a period of time where communication is really important and collaboration is really important. And what I want to show you is the importance of the RC for communication and collaboration with the committee. So as you know, we have been the Secretary's Advisory Committee. First, no financial disclosures. But we're now the Discretionary Committee on Heritable Disorders in Newborns and Children. And I want to say that the committees are the same. That we're the Secretary's Committee and the Discretionary Committee are really the same. And just to give you a little bit of background, the Newborn Screening Saves Lives Act, which authorized our committee, was set to sunset April 24th this year. And I don't say that we have a do-nothing Congress, but this Congress has been very slow to pass bills. And I think its record is its slowest Congress on record in terms of number of bills it's passed as of this time in the session. But included with that was the reauthorization for the bill. So therefore, our committee was set to sunset on April 24th. What Secretary Sebelius did was she authorized the formation of this discretionary committee. The Secretary has the ability to set up a discretionary committee, and that's what she did. And so in late April, probably within 2 weeks of the sunset of our Secretary's Committee, we became the Discretionary Advisory Committee. So we were chartered in late April, but to fulfill the same mission of the Secretary's Advisory Committee. The committee has been able to conduct the business that is necessary to meet its mission, and it will remain the Discretionary Committee. Actually, we have a 2-year charter, so if Congress really is very slow, we'll still be the Discretionary Committee for up to 2 years. But then when the bill is passed, and it has been now introduced in the House and is expected to be introduced in the Senate in the near future, we will continue as Discretionary Committee. Our membership was carried over, and all the contracts and grants were continued as well. So we are functioning as the Secretary's Advisory Committee. Now, there's some other issues, and it was already mentioned that money is tight and we have to be really careful, but HRSA has decided to try and save money by reducing the number of face-to-face meetings. That's one of the ways that they're reducing costs. And so the Secretary's Committee, towards the end of its tenure, met by webinar in January. Because of the fact that we were thinking that we might be on hiatus for a period of time, we actually scheduled a second meeting in April before the committee was to sunset. And so we had that in April. And then the Discretionary Committee was formed, so we had another teleconference in May. As you know, I think many of us believe that it's better to meet in person, and that interaction is much better and decisions can be made more strongly when we're together. So we have asked for the opportunity to meet face-to-face, and actually we have been granted permission for a face-to-face meeting for our September meeting. So our next meeting is September 19th and 20th. Again, to try and save money, that meeting will be held, it's expected it will be held at the HRSA headquarters in Rockville, but there will still be a webinar for the public and for other presenters who are selected to present at the meeting. I was asked to kind of give some idea of what the linkages are between the advisory committee and the regional collaboratives, and so we put together a list of things that I think are important. So the first thing is that the Discretionary Committee and the 7 regional genetic services collaboratives really are funded through the same legislative funding source, so that we really are a team to begin with and part of the same program. So we welcome your attendance at each of our committee meetings, and either by webinar, and if we get a chance to get back to full face-to-face meetings in person as well, and we want your involvement as much as possible in those meetings. We encourage your participation on our 3 subcommittees. The Discretionary Committee has 3 subcommittees which are public and open for membership or at least participation. And they are follow-up and treatment, education and training, and laboratory standards and procedures. And these committees meet each time the Discretionary Committee meets, and then there are teleconferences in between meetings to do subcommittee work. These committees are really working for the full committee and respond to the needs of the full committee as well as the needs of the research collaboratives. And so it's very important to have your involvement in these committees. These subcommittees are responsible not only for specific activities assigned by the full committee, but for searching and researching and developing either publications or other projects which would then potentially be endorsed by the committee, and in fact in some cases sent to the secretary for her either acknowledgement or for her approval. We engage the collaboratives in a variety of different project presentations, your projects. We'd like to hear about them in the subcommittees and then have them brought forward to the full committee when appropriate. And in fact, we'll endorse those projects and help them in terms of publication and again, bringing them to the secretary as well. And one example of that is the long-term follow-up project that came through us from this collaborative. We also acknowledge the RCs as partners for studies. You're our study arm for a number of things, for research sources, and again for publications approved by the committee. And again, 2 examples that are the medical foods and emergency preparedness projects that are underway or completed. We look towards the collaboratives to help support the recommendations made by the Discretionary Committee by providing guidance and disseminating that information through your region, through the public health programs within your region, to providers, and importantly to the families. And for example, the RUSP is one of the things as we make new recommendations and they're approved by the Secretary, to try and get them out as quickly as possible and help support the states in their efforts and the public in their understanding of the meaning of adding that to a new condition to the RUSP. And then, of course, the American College of Medical Genetics and Genomics, you've already heard from Dr. Watson about the progress in that area. They serve as the National Coordinating Center for the RC program, and Mike Watson himself serves as the representative, represents that organization to the Discretionary Committee. So we have a good link with the National Coordinating Center. Now then, your Southeastern Collaborative members certainly play an important role for us as well. I just listed Dr. Singh and Dr. Anderson, the program director and co-program directors. They're certainly involved with the committee and involved here, as you've heard, on a number of projects that are very important to the committee. And Dr. Singh serves as a member of our follow-up and treatment subcommittee as well. And then Dr. Kemper, who's also on the steering committee member here, is the actual lead of our condition work review work group, and so he has a very important role for the discretionary committee, and he also serves on one of our subcommittees as well. So there's good linkage and interaction on that level as well. So I wanted to just kind of briefly give you a couple of examples of the work that's been done, the accomplishments that were done by the Secretary's Advisory Committee and now into the Discretionary Advisory Committee's accomplishments over the past year and a half. One of the things, and you're going to hear this more from Alex, so I'm not going to go into details. You'll hear from this, I guess, later this afternoon. We had a very vigorous condition review that any nominated condition went through, but we needed to update that to really get to where we are across the country in evidence review and evaluation. So we held a evidence review summit in 2012 that led to a discussion and a presentation and then agreement at our committee meeting to expand our condition work group. We now have three work group report. We now have three components. There's the systematic evidence review, added the bounds of benefit and harm, and very importantly, we added an assessment of readiness and feasibility of implementing the comprehensive newborn screen from the State Public Health Department perspective. And we felt that was important. The Secretary told us that she felt that that was important, and we needed to really assess the impact and to determine whether states were ready to take on a new condition. So as we did that, we developed a new decision matrix which included these components, and I'm sure Alex has a picture of that, which she's probably going to show you, and provides a significant amount of detail. But to do this, we did include the evaluation. We've developed a partnership with the Association of Public Health Laboratories to help us with this preparation review. Now, during this time period, we had two nominated conditions which went to our nomination and prioritization review subcommittee that were then brought forward to the committee, and they met the requirements that we had for a formal evidence review by the condition review workbook group, and they were Pompe disease and MPS 1. And for Pompe disease, at our May meeting, the first meeting of the discretionary committee, the external evidence review report was given by the condition review work group, and the discretionary committee voted to include Pompe disease in the RUSP. So that's the next condition that we've recommended be approved. We sent that recommendation to the Secretary, and at the present time, we're still waiting for the Secretary's response. So the next condition is MPS 1 that will be evaluated, and external review is currently just getting underway. The other condition that came to us as a nominated condition was X-linked adrenoleukodystrophy, and the nomination and prioritization subcommittee recommended to the full committee that the decision about moving this forward be delayed until we had submission of data from the Mayo Biochemical Genetics Laboratory, which is producing a pilot study on the evaluation of detection of this condition. And so the committee did accept that report, voted to delay that decision until we had that data. And then a couple of other accomplishments quickly to review. We approved and acknowledged an enhanced description of the medical home and strategies for improving linkage between the medical home to children with heritable disorders. We submitted the report implementing point-of-care newborn screening to the Secretary. We supported the report improving data quality and quality assurance and screening by including blood spot screening collection device serial number on birth certificates. This would enable finding study results later on in life of children by having a link to the birth certificate. This was Secretary referred this report to the Interagency Coordinating Committee for its evaluation for final determination of acceptance of this report. And then we supported a report on insurance coverage for medical foods for treatment of inherited metabolic disorders. We supported activities related to the harmonization of newborn screening quality indicators that are being developed for use across the country. And we did support the CDC and the APHL in organizing the 50th anniversary newborn screening campaign for 2013. I think you're all well aware that we're 50 years from the first introduction of the Guthrie test, and the CDC and APHL are coordinating their efforts to make the public use this as an opportunity to make the public better aware of the benefits of screening, and so this is a campaign that's been going on for the entire year. There was a meeting which some of you may have attended, a symposium in Atlanta, and there will be some additional events that will occur in Washington, D.C. in September, right at the time that our discretionary committee is meeting. Here's some major subcommittee projects that are currently underway or nearing completion. The Laboratory Standards and Procedures Subcommittee is collaborating with the CDC to determine the current status of state screening programs testing for tyrosinemia type 1. And this survey will very likely be published shortly when it's completed in the MMWR. The Education and Training Subcommittee is finalizing the process by which the committee reviews conditions for possible screening outside the newborn period. And as you know, our committee has really focused on screening in the newborn period, but we also are tasked to look at screening for disorders potentially in children. And that obviously would create a number of different potential barriers or things that may need to be dealt with. So we're trying to select an example condition, identify potential barriers so we can sort of give a general view of the benefits or how we might proceed with that. We're working with professional organizations to identify specific priorities for newborn screening awareness and reviewing materials and plain language summaries of the conditions nominated to the committee but haven't been recommended, so that individuals interested in nominating a condition have a better understanding what might be needed and what could potentially be lacking that would prevent a condition from moving forward. The Follow-up and Treatment Subcommittee is looking at lessons learned from the early hearing detection and intervention RUSP condition to help inform critical congenital heart disease screening, since this is another point-of-care test that's being done with public health implications. And they're developing a framework for assessing outcomes of newborn screening. And then just to close, let me just mention that, as you know, we added critical congenital heart disease to the RUSP in September of 2011. HRSA then funded 6 demonstration projects in 5 states. And a number of states now have either implemented screening or in the process of doing so. And I'm happy to say that Louisiana, in legislative session, just approved the requirement for critical congenital heart disease screening, which will go into effect the 1st of August. But just in terms of outcome, here's a paper that was just published in Pediatrics looking at New Jersey, which was the first state that implemented this. And the data is pretty clear that they were able to identify they actually developed a program that they were able to screen 99% of eligible newborns, get the data back to the state through the newborn birth defects registry. And they picked up 3 children who otherwise would have left the nursery looking healthy but had critical congenital heart disease. They found a number of other infants that had other abnormalities that needed attention, with only 10 patients who may have had a false positive test. So I think that gives you a good perspective of making a decision based on data and then implementation and outcome within a short period of time. And here's the website for the Discretionary Advisory Committee, which provides a significant amount of information for the public as well as individuals who may be interested in nominating the condition and for professionals who want to learn more about the committee. So I think I'll stop there, and if this is appropriate, I'll entertain any questions or wait until later. Thank you very much.